Hey you all, I'm Dr. Atsla. Good to see you all again. And today I'm here to discuss a new topic, a new title including kidney diseases. It wouldn't be wise for me to discuss diabetic nephropathy as a most common cause of chronic renal failure and I had to start with the chronic kidney disease, but being a most important topic for us to discuss and our patients with coming with the uncontrolled diabetes and what all to be prescribed to them, it is really important for us to start with this topic. Felt that, and here I'm starting with this diabetic nephropathy. As we discussed, it is the single most common cause of chronic renal disease, and it is obviously related to obesity and type 2 diabetes mellitus. So 40% is the percentage of the diabetic patients who are who will be nephropathy, who will be undergoing kidney biopsy. Without even kidney biopsy, the patient can be diagnosed with the help of just a urine routine microscopy and his features of edema and say decreased urine output. So the risk factors include hyperglycemia, as stated, hypertension, dyslipidemia, smoking, family history, and genetic polymorphism. So we say that whenever the patient has been diagnosed with diabetes or clinical diabetes, then the changes in the kidney start to appear after just 1 to 2 years, and that is most important thing. As the rate of the fall of the EGFR is in the diabetes is almost 8 to 10, so that's a high number, right? So 8 to 10 milliliter per minute per year, so it's a havoc for us, right? So there is actually a reminder for us to discuss this with the patients, to analyze the urine routine microscopic picture and the creatinine levels, and making them follow up with us or any other doctor. Even if it is very hard for them, like I have seen patients who are coming after 6 months or after 8 months saying that they are living far away, but I just tell them that at least show to a nearby doctor so that you could be started on AC inhibitors or ARB so that we can control proteinuria. And that is the single most important factor, as it will go and cause inflammatory cascade and then fibrosis and IFTA-GS, that is I'll be talking about the interstitial fibrosis, tubular atrophy, and glomerulosclerosis that is seen. And I am discussing this with you all, as I personally feel this is a very important topic, and I have picked up certain things from Harrison, and I have made my notes so that it is useful for all you. So there is this thickening of the glomerular basement membrane, which is a most important sensitive indicator for diabetes. It correlates with poorly with the presence or absence of nephropathy, but when the MCQ says the sensitive indicator is the thickening of the glomerular basement membrane, and we shall see why there is thickening. It is because of the advanced glycation end products that has accumulated. um, Coming to the normal physiology or the normal thing that should be there. So there is this heparin sulfate as which is acting as a barrier, which is actually a negatively charged. But whenever there is a loss of this heparin sulfate, so there would be this proteinuria that would be there, and this is important. So when there is expansion of the mesangial and there is accumulation of extracellular matrix, that is correlating with the diabetic nephropathy. So this is important. I have also made a diagram for myself so that I can keep this in mind. There is expansion of mesangial and accumulation of extracellular matrix. Coming to the most pathognomic for the diabetic kidney disease, that is the Chemistry-Wilson lesion. Now this is just a pathognomic, but it is not seen in all the individuals, almost 40 to 50% of individuals, but it is a diffuse glomerulosclerosis that is seen in 80% to 90% of the patients. Chemistry-Wilson lesion is actually nothing but a nodular glomerulosclerosis, and which is seen in like a stage beyond stage 3 4. Okay, it is seen. So it is not an early manifestation as such, but it is pathognomic. Then there is a linear IgG deposit. There are bundle of the diseases which is having linear IgG deposits. So it includes diabetes, it includes Alport syndrome, it includes Guttspescher, it includes cadaver kidneys, it includes SLE. So you need to keep this in mind. Now, are the type 2 are the diabetic kidney disease and diabetes mellitus nephropathy the same? So actually not. Speaking in these terms, like we are most of the time defining that he is a diabetic kidney disease. He has this diabetic kidney disease. But is it really that the patient should have proteinuria, right? And the patient, it is diabetic. So it is nephropathy. But when the patient does not have any albinuria, then it is a diabetic kidney disease, and that could be of any other causes like AKI or any of the nephrotic syndrome which can occur in diabetes, okay, FSGS type. So this is has to be kept in mind, okay. So pathologic changes, there is the first hyperfiltration, and there is this increase in the glomerular capillary pressure. So we shall see the explanation to all this thing. First of all, there is hyperglycemia that is there, right? And that is causing whole bunch of the things, like there is reactive oxygen species which are increased. It alters the endothelin 1. It alters the insulin-like growth factor. It activates the renin-angiotensin system, and it upregulates the sodium glucose cotransporter. Now, the sodium glucose cotransporter, which is SGLT1 and SGLT2, we have the drugs. So, in the proximal tubule, so what will happen? So, there would be no sodium which is reaching the macula densa. And what will happen is the macula densa needs sodium for the activation of the adenosine, so that there is afferent arterial vasodilation, and that will not occur. And here on, there is this autoregulation that is taking place, which will lead to efferent arterial vasoconstriction. But this autoregulation cannot be there for much time because the kidney is being injured. There is an insult which is going on. And here there would be glomerular, mesangial, and the podocyte that will be damaged. Okay. And again, there is sustained rise in the blood pressure. So now there is sustained rise in a blood pressure. There is a increase in the matrix production, that we have seen that there is an advanced glycation end products that have been accumulation, and that is causing the mesangial matrix expansion. So that there is this also circulating factor, growth hormone, connective tissue growth factor, TGF beta, that are contributing to that. So there is this afferent arterial vasodilation that is there. So there is upregulation of SGLT2 in the proximal tubule, and which is sodium is not reaching the macula densa. So there is no afferent arterial vasoconstriction. There is the vasodilation that is taking place, and there is hyperfiltration and hyperperfusion injury. And this is the first stage. First, it is a stage 1 thing that is we can see. And there is increase in the GFR, and there is efferent arterial vasoconstriction. After a few days, there is loss of autoregulation, and that will lead to intraglomerular hypertension, wherein there will be mesangium which will be injured, that will cause sclerosis of the mesangium. Then there is this endothelium, which is the glomerule, which will be injured, and that will cause proteinuria. Then the podocyte apoptosis will take place, and there is nephrin, which is lost. There is decrease in the nephrin, that will lead to again proteinuria. Okay, so this proteinuria is the one which is causing crime. Okay, so this is tubulotoxic, which will inflammatory cascade is released, and there is fibrosis. I have discussed this earlier also. So now, first pathology that I have already said that it is the stage 1 hyperfiltration and hypertrophy, with that of intraglomerular hypertension with the microalbuminuria. Then the stage 2, clinically we can see the patient can come with proteinuria here. Okay, it is a fixed microalbuminuria, and there would be a glomerular hypertrophy, of course, and there will be symptoms like edema and everything. Then we have a stage 3 where the patient will complain of decrease in urine output. There is decreased GFR. And there is a proteinuria or albinuria, we could say. Okay, full blown proteinuria or albinuria. Then on the biopsy, there will be here that there will be thickening of the glomerular basement membrane, and there is expansion of the mesangium with that of the efferent and afferent arterial hyalinosis. When the stage 4 is reached, there is this nodular glomerulosclerosis, that is Wilson. Then there is diffuse glomerulosclerosis, and there is diffuse mesangial expansion as well. And stage 5 is end-stage renal disease. If there is a proteinuria, which is a trace one, and we are suspecting that the patient has gone into CKD, then why would be it so? So there is one attributed factor of hypertension as well in these patients. That means the vascular involvement is there, or it could be just a cholesterol embolism as such, and which is causing ischemic kidney disease. I will be talking about this as well in few days or so. I will drop a video on that. If the hypertension is present before the diabetes, there could be an ischemic kidney disease, as I just told you. So, coming to the retinopathy and the nephropathy, we say it goes hand in hand. For type 1 diabetes mellitus, it is so, it goes hand in hand. But in case of type 2 diabetes, it is like 60%, 65% patients have both. Now, do we perform biopsy in the such patients who come to us on like routine OPD basis? They come to us with edema and they tell us that there is decreased urine output. No. So when do we do biopsy? See, whenever the patient has land up into a diabetic kidney disease, this is the time where the patient comes with the symptoms. Nobody will come to you with saying that I want to have a routine checkup. That is in case of high fundo, high class society people. But in middle class or in case of lower class, they won't be even aware of this such thing happens. So you need to educate them, of course. So if it is so, with a patient coming with the symptoms, then it is highly likely that patient has gone into already an end-stage renal disease, or patient has already in the process of chronic kidney disease. When you are not suspecting it is to be a chronic kidney disease, it could be a secondary FSGS, that is a nephrotic range proteinuria is there, and you are suspecting something other than that of the diabetic kidney disease. This is the time where you want to do a biopsy. That is, if the patient has hematuria, if the patient has no edema, if there is no hypertension as such, okay, and if the patient does not have significant proteinuria, then the patient has no retinopathy. This is when you are suspecting something else, okay. So then we need to do a biopsy. So for these patients, we try, if the patient is a diabetic, then we go with the metformin, sulfonylurea, with that of GLP-1 analog, okay, with that of without that of HGLP2 inhibitor. This is the first line right now, okay. But in case if the patient has been in nephropathy, then we need to go with the HbA1c. If HbA1c says it is 9.5, even if the patient does not have nephropathy, it is more than 9, we need to go with the insulin. Here, if the patient has 9.5, then we are going with insulin, because the patient's requirement for that of the insulin will be also decreased. So you need to keep this very under a tight control, the sugar to be in tight control. I've seen patients who are coming to us with creat of say with saying that he or she has recurrent hypoglycemia, and when I do a creat, it is saying 1.7, 2.9, like that, and they're very happy that they have decreased the doses, because they won't see us, they will see other doctors, some other doctor will say that okay, fine, your glucose is under control, your diabetes is under control, you may start on tablets, and there's no need of taking insulin. And this is when they are in fox, right? They are not aware that it could be nephropathy. So you need to see RFT most of the times by like 3 months or so, and then we can say that if the patient is not if the patient has not landed up in nephropathy, then we can say yes, he is in under control. But if he has developed renal disease, that means the patient will require insulin, because most of the time EGFR will be less than 30, less than 40. Metformin cannot be given, even in DAPA, EMPA, less than 20, less than 30 cannot be given. So that's why you have to go with the insulin with the small dosage or like that. Um, BP, blood pressure, is same as that we do in our normal individuals. It should be 130 by 80, less than that of the 130 by 80. I forgot to tell you that the diffuse glomerular sclerosis, it correlates with the disease activity. It is not a nodular glomerular sclerosis. This may come as an MCQ. It is not a nodular glomerular sclerosis, but it is a diffuse glomerular sclerosis. So this is something which is a class we have divided the stages. So stage 1 is the mild non-specific light microscopy changes, wherein there is only the electron microscopy saying that there is thickening of the glomerular basement membrane. we have the class 2A, which is a mild mesangial expansion. Then we have a class 2B, which is a severe mesangial expansion. Then we have a class 3, which is a chemistry lesion and advanced diabetic glomerulosclerosis. So coming to the cardiovascular factors which are important. Now, when I say that most of the patients of diabetic have this atherosclerosis going on, and they can have CAD as well. Along with that, they have hypertension as well. So they have this multiple comorbidities, right? So there is albuminuria, which is the most important risk factor. We have already said to decrease the GFR. Okay. So now whenever the patient is coming with the, in case of a type 1, I have certain 5 years or 10 years say to for the patient to land up in nephropathy. But when it comes to a type 2, I do not have much time. I have to check for his RFT. I have to check for his retinopathy. Okay. See, the rate of fall in GFR in diabetic is 8 to 10 ml per minute per year. Very dangerous. Okay. We have seen that. And in diabetes, what will you see on the UHG? You will see enlarged kidneys, but then if there is a shrunken one, CKD, of course, below 8, okay, 8 by 3 or 6 by 2, like that, okay. What are the other conditions that could have enlarged kidneys at first because of the hyperfiltration and hypertrophy that is taking place? So that could be amyloidosis, okay, that could be HIV. Remember those. Okay. So there should be intense control of blood sugar. It is very important. The take home message is this. And I hope that you will understand how important is this diabetes and the kidney disease which is related. And I have started a series. I will go with the, of course, with the AKI also. And I will go with the glomerulonephritis, the MCD, the focal segmental glomerulosclerosis, all the patterns. And we will try to correlate everything. We will try to see where our patient fits in. And please tell me in the comments that if you want to have a lecture on any of the kidney diseases, including vascular diseases, say, or any kidney manifestations or any complications, and when to start a dialysis on and everything. I would like to address to those. Thank you so much for listening.